This is an 86-year-old female, severe symptomatic aortic stenosis. She's got a medical history of obesity, hypertension, dyslipidemia. She also has coronary artery disease, and we'll show you her images shortly. She had a recent angioplasty of the LAD on the 19th of June. At the time, she was found to have a ramus that was occluded, a 50% lesion in the circumflex. So she had PCI with a drug-eluting stent in the LAD. She was admitted at this particular time with progressive dyspnea on exertion, with symptomatic aortic stenosis. Her ECG showed sinus rhythm at 64 beats per minute, and her echo shows preserved ejection fraction at 60%. Quite a small left ventricle, 34/26. Mild pulmonary pressure elevation, a mean aortic gradient of 55 with a calculated valve area of 0.64. In terms of other significant valve disease, she has only trace mitral regurgitation, trace aortic insufficiency, and 1+ TR. She had a right heart cath, which showed RA pressures a mean of 7, RV pressures 45/5 with an end diastolic of 12, and a mean PA pressure of 27. So you can see this is the image of the left coronary system. So you can see she's got an occluded ramus quite proximally. No real significant lesion in the cert. So she had a CT scan which showed a perimeter of the aortic annulus of 69, almost 70, with an area measured at 368 millimeters squared, LVOT of 21.8. You can see the annulus itself is not calcified. The sinuses measure, their limit in terms of when we talk about our valve selection. And so we have sinuses that measure 26 by 26 by 27. You can see the pattern of calcification on the aortic valve leaflets. You can see calcification also in the LAD. We've already done our vascular access under ultrasound guidance. We've done our measurement for the MANTA closure device. And nuclear imaging did show ischemia in the territory of the LAD. So it's hard to know if that shortness of breath is just the aortic stenosis or if that's a component of her coronary artery disease as well.
The only small concern I will have is to be careful with this patient, old patient who have so many contrasts. And you need to evaluate the amount of contrast you have done for the angioplasty before repeating that about 2 days after.
We are planning, as discussed with Anita and with Raul, to deploy a Sapien valve. Based on our measurement, we will use a 23 Sapien valve. The main access will be the right femoral artery. We are going to cross the valve right away with Raul and put a safari wire, extra small safari wire.
You can see the valve leaflets themselves are quite calcified. So here you see the challenge of trying to get this catheter to go through that very calcified valve. The wire is through. So we have bilateral femoral access. There certainly are, a school of thought to go radial. We prefer to have bilateral femoral, particularly in this particular case where we have obesity. There's a concern for vascular complications, to have a quick crossover and be able to get around and manage the vascular access. So there's no one right way, but that's the way we've chosen to go. So you can see one of the leaflets is completely immobilized, very heavily calcified. So our pigtail looks relatively well positioned. If we could just advance the other pigtail, and we'll bring our safari in. So we pace on the wire, so we will connect our alligator clips to the wire itself once the device is in, and we'll paste directly on the wire. So we're just talking about, what's the best deployment, and so to the point that the coronary is a little bit low, as opposed to maybe a really high deployment, sort of 80-20 or 90-10, probably going to err a little bit more on a lower deployment, maybe more 50-50. Just trying to find the right angulation to be able to load the valve onto the balloon. Often it's more cranial, not in this case. Perfect. Okay, I'm going to connect the pacemaker. So the pacemaker is connected. We're going to flex as we go around. Okay, we're going to cross the valve. We've already tested the pacemaker. Okay.
Perfect.
We
I think
bring
we'll do
it
an
back.
angiogram here.
Wait a minute. I will just bring it back.
So we were aiming for 50-50, so we're going to do an angiogram here just to have a look. Okay, that's parfait, merci. Okay, so Cine, when you're ready, I'm going to shoot. Okay, Cine,
Okay.
we'll take an image.
Avancer un peu.
So I might advance it a little more. I find it a little bit high. On peut juste laisser jouer la ortho, s'il te plaît? Yeah, because we see the left main, so I think we need to advance it just a little bit more, which you probably already did, Fluoro. Just a little bit more. Perfect. Okay, so we're going to bring the pusher back. The flex is off.
Flex is off.
Okay,
Copy.
pressure is low a little bit. We're going to get that pusher back. Okay, perfect. So we're going to get ready to pace. On est prêt?
No, pick the.
140, s'il te plaît. Okay, everybody ready? Okay, pacing on, 140. Dog bone. Inject. Okay. Let's go. Full deployment. Balloon down. Pacing off. Okay, so we are in a bit of a junctional rhythm. YQRS. We'll see how she recuperates from that. We'll bring the system back.
Yeah. Be careful. The tip.
Yeah, we're just going to advance the lawyer.
Okay. Push back.
Okay, the pacemaker is disconnected. We're in a junctional rhythm right now. Ah, sinus is coming back. P waves are back. We're going to take the system out, and we're going to check a gradient, and obviously an aortogram to see the position of that left main. Parfait, merci. So she's back in sinus rhythm.
Back on sinus.
Yep. QRS is a little bit wider.
Yeah.
Blood pressure is good, and you actually can see a dichrotic notch on her aortic pressure tracing. Just going to advance our pigtail. A little bit of a waste in the valve. I'm not sure I would do much about that. We're going to see what the gradient is.
Yeah.
I think the important thing is here to avoid the ocular reflex and really have a hemodynamic reason why you're going to post-dilate something. Flush. So not much in the way of a gradient here. She's got a good diastolic separation, which suggests she doesn't have much in the way of aortic insufficiency.
But this diastolic is high.
And diastolic has gone up
Yeah.
from 21 to 36. What we're going to do is bring that pigtail out. Parfait. So she's got a gradient of 2. We're going to take this out and do an aortogram. Certainly the rapid pacing, and you saw that she had quite severe AI while we were positioning, and all of those things probably contribute to this elevated end diastolic pressure, but we're going to see, make sure we have nothing in the way of, okay, you want to just hold it there? Okay, I'll do an angio, Cine, please. Okay, so we see nice filling of the left coronary. The big window of the sapien is in front.
That's perfect.
We see nice filling of the left. Don't see much in the way of AI. There's a little bit there,
one
but
leaflet is not moving.
So Raul thinks there's a lazy leaflet. So we're going to see if we can encourage that leaflet to function. So basically just using the pigtail to push down on the leaflet and see if we can get it to get in the right position. I'm not convinced that's what's going on, but we'll see.
Donne un peu de coda pour l'aligner, s'il te plaît.
On peut juste aligner la valve. Donc, je sais pas comment. Essayer caudal, voir si ça aide. Wait, ça va mieux. Okay, we can do another shot. How much dye have we given? We've given 96 cc, so we can probably do another shot just to see. So we'll do another one, Sine. A bit of leak there,
You
but
see, this part is full. You see the leaflet on the left side.
mm-hmm.
On va lui la... Mais il y a une calcif là. That's okay. That's,
The other thing we could do is just make sure the valve is well expanded. So maybe just go in an RAO and have a look, make sure it looks round. Tends to be more of a challenge with the self-expanding valve, but it's always good to check. Because it was quite a heavily calcified. I mean, it certainly looks well deployed. We'll just try to make it a little more, peut-être un peu plus de cranial, je suppose. Non, c'est pire, l'autre sens. There's a little waste there, but nothing dramatic. It looks well expanded. Oh, I was going to inject.
Okay. Ready?
Yeah, 1 second. Just reload. Okay, so we'll go again. Cine. Honestly, I wouldn't do much about that AI. She's 88 years old. We've got a good hemodynamic result. I would leave that.
And we can hope
don't-
with the skirt to fix
Yeah,
this.
I don't think there's any value in post-dilating either. We
no.
can see our distance from the left corner. We have space. It's good filling.
Okay, on fait.
I think this is time now to focus on the vascular access closure. So we'll go back to AP.
On lève l'aiguille. On lève l'aiguille.
So I'm going to put a stiff wire here. And we're going to cross over.
Okay.
I'm going to cross over and then we're going to do the MANTA. For those of you who saw our case last week, we do the MANTA under ultrasound guidance. So I will just leave a stiff wire on the valve side, and then I'm going to cross over on the other side. We're going to leave our wire in though. Try not to take it out. Here, why don't you want to take this?
Thanks.
C'est vrai, une image claire.
Okay, let's advance the wire in there. Okay, I'll take a 35. Je prends le 35J pour faire le crossover. J'ai juste besoin de voir l'écran pour l'instant. Là. C'est peut-être pas trop loin.
Okay.
Un bleu, un champ bleu, ça.
What we're going to do is do our crossover that we discussed previously, so I can take the pedal. On va juste enlever le point suture. Prends la mammaire, s'il te plaît.
C'est à droite, ça.
So use a mammary catheter to cross over. We'll get our crossover access before we close the MANTA.
On peut donner de la protamine, s'il vous plaît? Moitié dose.
And we're giving protamine. No wire. Maybe a med if you want to come here next to me, please.
40.
Okay.
S'il vous plaît.
Okay, you want to bring your sheath down? Okay, do you want the dilator?
Yeah.
Okay, you have the
Please.
dilator. We're going to put the dilator back in the E-sheath. I'm going to try to cross over. Imaging is challenging because of the size of the patient. Okay, so we're crossed over. I'm going to come down a little bit lower. Can you bring yourself down a little bit lower? Yeah, that's perfect. Okay, so I'm going to leave that there. J'ai pas compris. Okay.
Pas grave. On va rapprocher le MANTA, s'il vous plaît.
So we're going to take the ultrasound, please. On peut avoir le son d'écho, s'il te plaît? On peut reculer les écrans. On peut augmenter peut-être un peu les lumières. Parfait. On peut peut-être tirer la table vers nous. Okay. We're just getting our ultrasound ready.
Changer, si tu veux.
Hmm?
Je vais sortir ça, mettre le MANTA.
Okay. So I'll take out the sheath and then we'll put our Manta delivery in while we're getting our ultrasound ready. So we already pre-measured. C'était quoi la mesure, Lucie, encore? 4.5? Lucie? 5? Okay. Okay, so we're going to put our ultrasound and have a look. Okay, so while it's going to do the ultrasound, while I just take out the dilator, prends les compresses sèches, s'il te plaît. Merci. A little challenging to see. Donc on a dit 5, c'est ça? Okay. Okay. This one's a little bit harder to see. She has a small hematoma there from her right heart cath. Prends les compresses mouillées, s'il te plaît.
Je vois quand même bien.
Okay. So in with the Manta. Make sure I can click. Okay, I'm just gonna make sure we can see the measurement. Okay, so I'm gonna call out the numbers. Okay, so I'm at 10, 9, 8. Do you see me?
Yeah.
Oh, you see the wire? 7, 6, 5. Anchors are open.
The anchor.
Okay. All right. 45 degrees. Pulling out. Green, blue. Green, yellow.
No.
Collagen is down.
Yep.
Okay.
Let's see in cross section if we see the results. We can show.
Yeah, so you can see the collagen plug. The imaging's a little bit more challenging here, but we're going to take an angio now. So Ahmad's going to inject for us. Est-ce qu'on peut aller en angulation, s'il te plaît? I'm going to take out the wire of the Manta device. So you see the radio-opaque marker of the Manta device. You see very nicely there's no bleeding, there's no oozing. Vascular access looks good. We thank you for being here to watch our case. Thank you on behalf of the rest of the team. I hope you have a good afternoon.